a scientist can sign a consent form for himself. That does not make the experiment wise. We are here to determine the GOAT of documented 20th century biomedical self-experiments with durable clinical or safety impact. The field has documented 20th century biomedical self-experiments with durable, clinical, or safety impact. Yet some of medicine's sharpest turns began when a researcher stopped asking for a volunteer and quietly became one. Self-experimentation means deliberately testing an intervention, exposure, or procedure on one's own body. It can remove the delay of recruiting subjects, but it also concentrates risk, enthusiasm, and bias in the same person. The researcher knows what outcome he hopes to see, controls the procedure, reports the symptoms, and often decides when the experiment has succeeded. One body cannot provide a control group, reveal rare effects, or prove that anyone else will respond the same way. A dramatic result may be a clue, not a conclusion. History also records self-experiments that caused permanent injury and death. Even a survivor may produce a story that is memorable precisely because it was extreme, not because it was reliable. So courage alone earns nothing here. The field has documented 20th century biomedical self-experiments with durable, clinical, or safety impact. The test must answer a real causal question, survive later scrutiny, and change what professionals do. We will weigh personal risk, clarity of evidence, reproducibility, reach, and necessity. A stunt that merely confirms the obvious loses to an experiment that breaks a false model and gives later researchers something precise to test. The best self-experiment is therefore a paradox. It must be personally bold, scientifically modest about what one case can prove, and valuable enough that larger studies can carry the result beyond one unusually committed body. 3 contenders approach that standard from different directions: a disease investigator who swallowed contamination, a physician who used a rocket as laboratory equipment, and a young surgeon who threaded a tube toward his own heart. Joseph Goldberger entered a public health disaster in the American South. Pellagra caused inflamed skin, diarrhea, mental deterioration, and death. Many authorities treated it as an infectious disease spreading through crowded institutions. Goldberger noticed a social pattern instead. In orphanages and asylums, residents became ill, while staff eating better food often did not. When he improved institutional diets with milk, meat, and fresh foods, new cases fell sharply. To attack the infection theory directly, Goldberger and volunteers held what newspapers later called filth parties. They swallowed capsules containing material from patients and exposed themselves to blood and secretions. None developed pellagra. That was brave and persuasive, but it was negative evidence. It showed what pellagra probably was not. Goldberger's stronger proof came from controlled diet work, and the exact missing nutrient was identified only later as niacin. John Paul Stapp faced a different uncertainty. Aircraft were becoming faster, but engineers did not know how much violent deceleration a restrained human could survive. The answer mattered whenever a pilot ejected or a vehicle stopped in a fraction of a second. Earlier safety assumptions were often based on machines, corpses, or guesses, none of which could describe pain, vision loss, or the limits of a conscious human. Stapp repeatedly rode rocket sleds himself. On the most famous run in 1954, Sonic Wind No. 1 accelerated him to 632 miles per hour in 5 seconds, then subjected him to roughly 40 times gravity in deceleration. The stop burst blood vessels in his eyes and left him temporarily unable to see. Across the program, he suffered fractures and other injuries, while cameras and instruments recorded what happened to a restrained body under forces once considered unsurvivable. Stapp's data improved harnesses, ejection systems, and the case for effective automobile restraints. Still, no single ride carried the argument. His achievement was a disciplined program of escalating tests, with his body serving as one especially determined instrument. Werner Forssmann then crossed from measuring danger to opening a route into the living heart. In 1929, the 25-year-old German doctor believed a flexible catheter could reach the heart through a vein without open surgery. After his proposal was rejected, Forssmann inserted a cannula into a vein at his elbow and advanced a catheter about 65 centimeters. He then walked to the X-ray department so the tube's position could be photographed. The image showed the catheter in the right side of his heart. It was an astonishing proof of access, but not yet a mature clinical technique. Forsman was criticized, and the immediate medical establishment did little with his result. Years later, Andre Cornen and Dickinson Richards developed reliable cardiac catheterization for measuring circulation and diagnosing disease. Their work transformed Forsman's dangerous demonstration into a repeatable medical platform. Catheters could now measure pressures, sample blood, inject contrast material, and reveal how a diseased heart was actually functioning, rather than merely how it looked. Forsman shared the 1956 Nobel Prize with them, and he is the strongest rival here. His self-test opened a literal path into the heart. Its limitation is equally clear. Later teams, not the original demonstration alone, made that path safe and clinically powerful. Barry Marshall is the GOAT of medical self-experimentation. His test did not merely prove that a procedure was possible. It attacked the accepted cause of a common disease and helped turn long-term management into curative treatment. The story began with pathologist Robin Warren, who kept seeing curved bacteria in stomach biopsies. Marshall, then a young physician in Western Australia, joined him to investigate whether the organisms were more than harmless passengers. The prevailing model blamed peptic ulcers mainly on excess acid, stress, and lifestyle. The stomach was considered too acidic for bacteria to live there. Drugs could suppress acid and surgery could reduce it, but recurrence remained common. Warren and Marshall saw an awkward alternative. A bacterium might cause chronic inflammation and help produce ulcers. Their first cultures failed. The breakthrough came when plates were left incubating longer than usual over an Easter holiday, and colonies finally appeared. Associations in patients were suggestive, not decisive. Critics could still argue that damaged stomachs merely allowed the bacteria to move in afterward. Marshall wanted to reverse the arrow of causation and show that infection could come first. He first underwent endoscopy and biopsy to establish that his stomach was healthy and free of the organism. Then, in 1984, he drank a culture of Helicobacter pylori prepared from a patient. Within days, he developed nausea, bad breath, loss of appetite, and vomiting. A second endoscopy showed severe gastritis, meaning inflammation of the stomach lining. Biopsy samples again yielded Helicobacter pylori. The experiment established a causal sequence in one person: no infection, deliberate exposure, colonization, then acute gastritis. It did not prove every claim. Marshall did not develop an ulcer, and one subject could not measure frequency, long-term risk, or the best treatment. That restraint matters. The self-test was not the whole case. It was the sharp causal pivot inside a larger program that included patient observations, pathology, cultures, treatment studies, and work by researchers around the world. Marshall took antibiotics and recovered. Later clinical trials showed that eradicating Helicobacter pylori could heal many ulcers and greatly reduce recurrence, rather than merely quieting acid, while the underlying infection remained. The shift was enormous. A disease associated with repeated pain, bleeding, hospitalization, and sometimes surgery became, for many patients, an infection that could be tested for and treated with a course of medicines. Helicobacter pylori was eventually linked not only to most duodenal ulcers and many gastric ulcers, but also to elevated risks of stomach cancer and a gastric lymphoma. The causal model kept expanding beyond the first self-test. That expansion is important because it shows the difference between a heroic anecdote and productive science. The original clue generated predictions that kept surviving new kinds of evidence. In 1994, a United States consensus conference recommended antimicrobial treatment for infected ulcer patients. In 2005, Marshall and Warren received the Nobel Prize for discovering the bacterium and its role in gastritis and peptic ulcer disease. Forsman opened an extraordinary technical route, but others had to convert it into a dependable clinical system. Marshall's experiment landed closer to the center of the disputed mechanism. It gave a false disease model a direct causal wound that later trials widened. This does not make self-experimentation a shortcut around ethics, controls, or review. A researcher can be a willing subject and still be biased, reckless, or scientifically uninformative. Modern medicine needs evidence that protects people, not legends that merely impress them. Marshall wins because personal risk produced a clean causal clue. That clue survived replication, and the result changed ordinary treatment across the world. The lesson is not that medicine needs braver stomachs. It is that courage matters only when other scientists can test it and patients can live by it.